Hello, everyone, and welcome to Your Health in Your Hands. I'm Dr. David Ajibade with the Brain and Body Foundation. Now, if you remember, a couple of years ago, I did a show, an episode called Why Blacks Die First. And we looked at a lot of things that kind of like separate us from, white people, especially being in Nigeria, being in different environments, our lifestyles, our food, our diet, our genes. And there were a few things I pointed out. For instance, vitamin D. We said how that we as Black people tend not to have as much vitamin D as white people, except, of course, if you're out in the sun without your clothes on. Maybe you're working on the farms or you're hawking stuff in the streets. But for the most part, we are deficient or we have less amounts of vitamin D. And I try to explain how that can affect your health in the long run, starting from when you're a child, and how that can set you at a deficit. And we talked about the importance of supplements. Well, shortly after that show, COVID came around the scenes and people were dying all over the world. And again, I kept on emphasizing vitamin D, not because it's a prevention or a cure for COVID-19, but because it helps with the immune system. And one of the things that we knew about the COVID-19 was that it targets the immune system. It sort of revs it up, makes the immune system more aggressive and making the immune system attack your organs and other parts of your body. So we talked about vitamin D again and again. And of course, we also had a few other doctors like Dr. Edionwe who talked about some of the blood tests that they are seeing that Black people tend to have in the United States, lesser amounts of. One of the things that she pointed out that I didn't know existed was that we as Black people have more iron deficiency and anemia, and we have lower red blood cell counts than white people do. Now, these may just be like trivia to you, but in the long run, some of these things really, really, really matter. So it was my passion really to really find out and really go into this whole topic and see more and more about how we can point out to you, the average layperson, the things that we as Black people must be aware of so that we can take the right precautions, whether that's diet, supplements, lifestyle changes, so that we do not fall prey to many of the conditions that we are seeing that Black people have more of. For example, cancer, prostate cancer, breast cancer, we are by far. And our guest today is going to talk about them some more, so I don't want to jump into that too much. But one aspect that really concerns me is Alzheimer's disease. Black people are twice as likely to have Alzheimer's disease and have it worse than white people do. And there's a lot of research into Alzheimer's disease, not as much into Alzheimer's disease in Black people. So it's very important that we continue to explore this and investigate this. Now, without much further ado, I'm going to introduce our guest today. His name is Dr. Greg Hall, and he is in the Cleveland, Ohio area. I hope I got that right. He's going to say a few more things about what he does. But the way I found him out was that I was just telling him before the show started that I saw that potassium, we were deficient in a substance, a nutrient called potassium. And so I went online to see who else was talking about it. And that's how I came across his work. And he, amazingly enough, is so into this. I can't tell you how happy I was to meet him. And so I tried to find his contact details, and we found him out and asked him to come on the show, and he graciously accepted. So Dr. Hall, thank you so much for coming on today.
Well, thank you. Thank you for having me. I appreciate it. Great opportunity.
Absolutely. I'm seriously hoping this is only going to be the first of very, very, very many, as many as you can afford for us. So let's get into your work and your passion, because I see that this is going on. Let's say a few things about what you do and how far you've been doing it.
Yeah, well, thanks so much. I've been a doctor I graduated in 91. I finished residency in 94. So I'm coming up on my 30th year in practice.
Wow.
As most Black doctors in whatever hospitals or wherever they are, you're always asked to speak about health disparities and the differences in the care and the things of that nature, whether you really are interested in it or not. And I was appointed probably 20 years ago to Ohio Commission on Minority Health, the Ohio Commission on Minority Health, and I knew nothing about health disparities. I mean, I knew nothing about them. Right? I had gone through medical school, pre-med, residency, and never had anyone talk about health disparities. If you can imagine that, I knew nothing about it. So when I was appointed, and so now I've been appointed to a 12-man commission about health disparities, and I'm one of the 12 that knows nothing about it, right? And so I started reading before the first meeting, and as it were, I have great attendance for stuff, right? So within a year, I was the vice chairman of the Ohio Commission on Minority Health. And
Wow.
within a few years of that, I was the chair, and I had to give a talk every time. I would give an educational session at the beginning of each of these commission meetings we'd have in Columbus, the state of the capital of Ohio. We'd have every other month. And so every other month, I'd have to put together a talk, and I would see that, African American, I would just see all this staggering information that I didn't know about, most people didn't know about. And most of the people on the commission, I wasn't the only one who kind of didn't know about these things. And the largest burden by far was always African American. And as part of this commission, we were to address Hispanic, Latino, and Asian American health. And so I had to always make a point of trying to wedge in some Hispanic, Latino health problems or some Asian American health problems, but it was always just so much African American death and dying and disease. I always spent more time on that. And I felt like, well, I'm Black, and now I'm spending more time on Black stuff. I'm not being fair, right? So, but what I learned is, it's not a minority health problem. It's a Black health problem. It's an African American health problem. That's the problem. Here in America, the Asian Pacific Islanders have an average life expectancy of 86, right?
Wow.
African Americans have a life expectancy of 74. This is men and women combined, right? American males, we're 72, right? So so that 12-year difference between the life expectancy of an African American and an Asian American, white Americans average is 78, right? So they don't live as long as Hispanic Latinos or Asian Americans, who have the longest life expectancy. So our health problems are not minority health problems. Our health problems are African American health problems, and also Native American health problems. But in Ohio, there are not a lot of Native Americans, so it wasn't a population that I was actually seeing. So once I realized that the problem wasn't minority health, wasn't urban health, wasn't diversity health, it was African American health, and I wanted to say, we've got to put a name to it. So I even though the commission was looking at that, I said, when I'm done with my term here, I'm going to focus and zoom in on the real problem with health disparities, which is African American health. And so I just started reading about, whenever I'm in my spare time, I'm reading about African American health. I'm writing about African American health. I'm speaking about African American health. I'm putting African American name in the title, right? When I wrote the book, Patient-Centered Clinical Care for African Americans, the book got rejected 8 times, and they kept saying, write about Hispanic Latinos, write about Asian Americans. I don't know anything about them. I don't have any patients. I might have 5 Asian American patients, in my practice. Even fewer Hispanic Latinos, but they want it to be a minority problem. And so if you address it as a minority problem, the issues that Hispanic and Latino Americans face, usually language barrier issues. It's not, and it may be some poverty issues. African Americans we have more trust issues. We have, issues related to diet and culture, to where we live, to lead exposure, to, health illiteracy, to just illiteracy in some cases, poor schools, right? Yeah. And so our problems are different than Asian American problems related to something totally different. So it's been very rewarding, because I become this national expert, which is crazy to me, on African American health. It's crazy that I had to be the person to write the first book on it, and to be the first person that says their practice, that they specialize in it, be the first person to set up a nonprofit that has it in the name. And right now at University Hospital, we're establishing a center for African American health, and it's just fantastic. And that's going to be the first in the country. And people say, well, why didn't this historically Black college do it, or this historically, why? I don't have the answer. I don't know why they didn't do it, but I know why I am doing it, and why I'm going to keep doing it, because I think I can see the needle moving.
Oh, that's so you're seeing people begin to turn around, people in the medical health profession or just the lay people? I mean, when you say needle moving, what do you mean by that?
Everybody gets it, right? So
Okay.
so my book has already been picked up for the second edition, right? So all the begging I had to do for the first, people are buying
Now
it.
they're begging you.
Now they're saying we got a second edition. I don't even know when I'm at the time to write. But now I don't have to get all those rejections in order to do that. When we set up this center for we're in the process of setting up the Center for African American Health at University Hospitals here in Cleveland. It's been shocking to me how well the community has embraced it. People of all races are nodding their head. Yes, we do need that. It is time for that, and it's time for, people are kind of tired of hearing about health disparities, and no one's, we spent a lot of time complaining. I spent a lot of time complaining about Black health outcomes and complaining
Right.
about health disparities. And I really got
Right.
tired of complaining, really, and said, I'm going to do something. I'm going to develop a multivitamin. I'm going to write a book about it. I'm going to, we're going to start a center, and we're going to start doing research. And Black people will accept research from another Black person than they would accept it from, someone else. And so,
Right.
and so we can advance what we know about best practices, and we can advance what we know about what tends to work in our community.
Absolutely. This is so heartening for me because, as you know, you probably know, but Nigeria has the most number of Black people on the planet.
No, I didn't know that.
By far, the country with the most number of Black people on the planet. So anything that's you're finding out here, we need to translate to Nigeria, and that's why I'm so glad we can have this talk. Yeah,
Look, I did my 23andMe, and most of my African roots come from Nigeria. Believe it or not.
No kidding.
Yes,
the
Igbo. Yes.
I was hoping you would say Yoruba. Then I was saying, yeah, we're brothers.
Right, but that's what 23andMe. It's what it says.
That's interesting. That is interesting. Well, fantastic. That's well, we are brothers then.
Absolutely.
So one of the things that and I'm speaking about healthcare professionals, it's so important for them to catch on. I have a friend. He's also a doctor. He moved from Wisconsin to Tulsa, Oklahoma. He's since left, but he wanted to do his annual physical, and so he does his usual. He specifically looks for a Black person, a Black doctor, who will obviously understand his needs a lot more, and they run all the tests. And then finally, I was like, okay, when he told me, I was like, well, did they check your vitamin D levels? And this isn't the winter, so this was a good time to check it because most people's levels go down in the winter. And he said they didn't even talk about vitamin D. And I'm like, why would you not do that? I mean, to me, it's almost common knowledge now that everybody should know that people who are Black have lower levels of vitamin D. And so those are things that make me wonder that we really need to get a hold of this. Thinking about prostate cancer in males, Blacks having the highest rates by far than any other race. So let's talk about some of these conditions now. You've mentioned the social-cultural, socio-economical problems like distrust and society and access and all those things. And I like you just alluded to, I think many times people just stay on that and they say that the system is unfair, it's institutional racism. And of course, those have factors in it. But from what I'm hearing from you, there are also shall we say, the genetic factors, the lifestyle factors, and things that maybe we cannot control our genes, but we can control our lifestyle and our diet. So let's talk about that a little bit and see how that relates to these diseases that we seem to have a lot more of than the white people do.
Yeah, well, and it's as you know, that's a loaded question that has.
I know it's a lot.
A whole lot of tentacles to it, right? But it's it's true. Like you mentioned, you mentioned the vitamin D levels, and so people, the majority population here in America just tends to think of themselves most, right? It's because just the same way we think of ourselves. We think of African Americans, more so than we think of other communities. And so it's like the majority population doing that. And so the medical care that most people get is the medical care that white Americans need, right?
Specifically white males, because I hear the white females are beginning to complain about it as well.
And you're right, and that's true, right? And so white American males don't need a vitamin D test. They don't need a PSA screen. You know, they don't need to be screened for prostate cancer as aggressively. They don't need, you know, there's a lot. They don't need to take zinc supplements. They don't need to take potassium supplements. And so that's what's taught in medical schools. That's what's taught in residencies. You know, I mean, those approaches. And that's why I didn't know anything. You know, I trained at Cleveland Clinic, you know, one of the best hospitals in the world. They were thinking about, you know, best practices in African Americans, and not that anyone was, right? Or the Mayo Clinic or Harvard or any of those places, they weren't necessarily trying to spend any time on that. But what's happened, and I think a lot of that grew out of African Americans. We spend a lot of time wanting to be the same. We're just like you. We're just as good as you. We're the same as you, except for the color of our skin or the grade of our hair. And we push that a little too far, right? Because we're not just like them. You know, we're 99.99% the same, but that 0.00 whatever percent that's different makes all the difference. You know, that's where your increased risk that you mentioned earlier about, you know, increased benign ethnic neutropenia, increased low white blood cell count, increase, you know, I have APOL1 gene that runs in my family. It gives premature hypertension and kidney failure. That's a gene that really comes from Africa that it allows protection to African sleeping sickness. Actually, one gene or two copies of it gives you protection to African sleeping sickness, but the trade-off is you get increased hypertension that leads to kidney failure. And I've had two uncles die in their 30s with kidney failure, and I have a brother who died in his 40s from kidney failure. And so it's a burden. That's a gene. You can't change your genes, you know, but what you could do is start screening for that gene and treating the blood pressure more aggressively. So we can, there's things that we could do to put off kidney failure, to bring down the blood pressure, and try to, you know, maximize health in people with those populations. So, and then there's, you know, there's dietary issues. We mentioned earlier before the show that African Americans tend to eat less, you know, they drink much less milk, right? So where are you going to get vitamin D? And you're either going to get it from the sun or from vitamin D milk, right? We're not in the sun. We're not drinking milk because of increased lactose intolerant, which is also tends to be genetic. And so we tend to, you know, we eat more chicken, you know, so that rumor tends to be true. You know, we eat a little bit more fish, but we'll eat less of other things, you know, there's dietary patterns where we tend to eat less processed food. You know, people, for whatever reason, we like cooking our own food. There's not,
we eat less processed?
Less processed food in the form of pre-prepared foods. Now, there's also a lot more fast food, right? Which is processed. But I'm saying when you look at the grocery cart for an African American, you're not going to see Swanson's TV dinners, a lot of Stouffer's frozen dinners. You're going to see we tend to cook more food from scratch, but there's still bad habits. You know, my mother did. You know, you got to put a ham hock and some greens. So now we're putting smoked turkey into you know, greens or vegetables now. Whereas my mother and my grandmother would put a piece of pork, you know, salt pork into those vegetables. And so we tend to cook vegetables more than eat them raw. So there's all these things that education can help us to migrate to better practices that really won't impact the quality of our lives. And there's some things that we can do, like you say, just taking a supplement, just taking a vitamin D supplement at the right amount. So the recommended daily amount of vitamin D you need is 600 international units. So you being what? The white male we talked about, 600. So African Americans need way more than that, 2,000. And that's if you're not deficient. You know, I mean, if you're deficient, you need to take even more to get to the point where you're not deficient. And then you need 2,000 on a daily basis beyond that. And so, and you mentioned prostate cancer. People have linked the increased prostate cancer to increased zinc deficiency. And that zinc deficiency has been linked to the increased HIV epidemic and the COVID susceptibility. And because zinc fights off infections, it fights off all kinds of flu, the cold, COVID, all those things. Zinc has been shown, increased zinc levels have shown to fight that off. And when we see that increased burden in communities, in African American communities, they're attaching that to some widespread zinc deficiency. And there are foods that are higher in zinc we don't get. We don't eat a whole lot of salmon, fresh
oysters, shellfish, all that good stuff. Yeah.
Right.
Oh, no. Well, okay, let's talk about zinc. Since we talked about zinc on prostate cancer, can we lean into that a little bit? Let's look at some of the other things that make us as Black men more susceptible to prostate cancer. So we know zinc for one. Is there anything else that you want to talk about with regards to that?
Well, vitamin D deficiency is associated with increased risk for colon cancer, prostate cancer, diabetes. There was just an article a couple of days ago that showed that if that the deficiency of vitamin D leads to increased diabetes, and who has the highest rate of diabetes in the country? African Americans. And I don't know if it's related to obesity and diabetes. I know obesity is related to diabetes, but it just makes you wonder, you'll have some young, thin person with diabetes. And I wonder whether, this is really a vitamin D deficiency or some other kind of a deficiency, magnesium deficiency or whatnot. So it's just that, we're at risk for all sorts of things. And then by educating yourself, you can figure out what's the best way. I'm still going to be Black at the end of the day, right? That's not going to change. That's not going to change. So we know I'm still going to have that APOL1 gene at the end of the day. That's not going to change. So, but what can I do with knowing exactly what I am and where I live? What can I do to maximize my health? And that's kind of what we're doing, just providing an opportunity for people to talk about and say, if you're Black, you probably got a vitamin D deficiency. It can't hurt by taking some every day, right? You probably have a zinc deficiency. Can't hurt by taking extra vitamins, taking extra zinc. There's no problem with taking. You take too much of anything, but you know what I'm saying.
Yeah, I mean, at least if we know what the basic requirements are. I mean, I agree with the vitamin D recommendation in my mind. My mind is ridiculous. In fact, sometimes I think RDA stands for ridiculous dietary recommended, because certainly they weren't thinking about Black people when they came up with those numbers. But obviously there has to be there's need for caution, obviously. But there are some general recommendations, like I know for zinc is like 15 milligrams to about 20 or 25 milligrams. I'm not sure now, per day. I mean, you can't go wrong taking that amount. As a matter of fact, we had a Dr. Mensa. He's also based in Chicago, and he's like, one of the reasons why there are so many, and I know this is a little bit on the other end of the spectrum now, but the reasons why there are miscarriages, they found out that there are more miscarriages in baby boys than there are in baby girls.
Right. And
he said it's because of the zinc deficiencies in these pregnant women, because zinc is needed boys need more zinc to make their testosterone and so on and so forth.
Wow.
And if the zinc is not in high enough levels, that pregnancy is just not going to be viable if it is a male pregnancy.
That's amazing. That goes along. I love that I'm doing this with you today, because I'm learning as much as anything. The organ in the body that's highest in concentration of zinc is the prostate. The prostate.
It's the prostate. Oh, okay. I'm sorry. It's prostate. Okay.
Is the highest concentration, and so that's all that. So if you can't develop a prostate, and the prostate's supposed to be there, then you abort the mission, right? I mean, if you can't, so that makes absolute perfect sense. And I never knew before, again, researching for the book, that the prostate was had the highest level of zinc. And so again, if you're not having the right zinc, and zinc blocks, I said zinc blocks infections, right? And so we found that cancer in many ways is like an infection. You know, I
Right.
mean, in many ways. And so it's like it's way more related to, you know, our propensity to form a cancer is there throughout our lives. But as we get older and our immune system starts to wane a little bit, then cancers can form and spread. And that's why as we get older, we get more cancers, right? And so
Right.
if we're zinc deficient, that's going to happen at a much higher rate. But it's also important that, you know, I'm a doctor first, right? And so the best way to get best health is through eating it. It's better to eat something that's high in zinc than to take a zinc tablet. You know, that's 7 days a week, right? You know what I mean?
Yeah, Doc, but we got to work with what we have. Now,
We do have to work with what we have, right?
most of the people watching this program are not going to have access to all this nice genetic lab tests where they can just test to see their zinc levels or their ApoL.
Right.
They're not going to just see what their risks are. So what we've always tried to do is say, okay, we're going to assume they can't test these things. What is the safe thing for them to do? So obviously, vitamin D has a very wide safety margin.
Very wide.
If you, in fact, Mayo Clinic, interestingly enough, I checked on the Mayo Clinic site. During COVID-19, Mayo Clinic said that you could go as far as 60,000 international units a day for months before you get toxic, before you reach toxic levels.
Absolutely.
But they took it off afterwards. For whatever reason, maybe they were afraid that it would be abused and all that, but they took it down. But it was on Mayo Clinic website. So yes, vitamin D has a very safe, long, wide safety margin. Most of my patients, in fact, I can't think of any that hasn't had good results. When I started them on vitamin D, and many of my patients, I just started them on 10,000. I know that's a little high, but I started them on 10,000. And
they're deficient. They were saying that when you're deficient, you can't just take 2,000. You're deficient, you got to take much more to get you into sufficiency. Then you need at least 2,000 to maintain it. But you're right, the odds of being, you know, overdosing vitamin D are very small.
It's extremely small. And so without exception, they've seen something improve, whether it's lower back pain or they don't have malaria like they used to. Some of them were having malaria every single month. And of course, it's endemic in Nigeria. But that just stopped. That just stopped because and of course, some had even better blood pressure readings. Obviously, I'm not saying that this treats these things, but I think there are several pieces to the puzzle for several different kinds of illnesses. But if you start from the more basic fundamental needs of the body, and I believe vitamin D is one of those pillars, if we can call it that, it helps in so many different areas of health and disease.
It's true, you know, it's true, and you can get help and it can't hurt, then right? It's a no-brainer, just like what you're saying. It's a no-brainer.
So I think if we have more time for another show, another 30 minutes per chance, I would like us to start looking at certain, maybe if we can just talk a little bit about certain nutrients and what you've seen and how helpful they are, or we can talk about certain conditions. Just like we talked about the prostate cancer, and say, okay, what are some of the things that are missing and deficient in these things that we have found out over time? And of course, we'll talk a little bit more about your book as well. But if you don't mind, tell us what the title of your book is.
Oh, it's called Patient-Centered Clinical Care. Yeah, patient-centered clinical care for African Americans. Again, it's on Amazon. It's easiest way to get it. It's a little overpriced, but I didn't price it. It's the price. Again, it's for doctors and providers, but my patients have found some value in it. So again, I appreciate the opportunity. Be happy to come back.
Absolutely. Thank you so much for making it today. And we hopefully will talk about this some more. All right, folks, thank you for joining us. Dr. Greg's website is
DrGregHall.com. Dr. Greg Hall, DrGregHall.com.
DrGregHall.com. You can check him out there. In the meantime, folks, you can always watch our past episodes on our website, brainandbodyfoundation.org, or on our YouTube channel and other social media platforms. Brain and Body Foundation. Thanks for joining us. We will see you next week. God bless. Bye.